Bismillahirrahmanirrahim. Hello guys, and today we are going to discuss about the magnesium electrolyte imbalance. First of all, we will talk about hypomagnesemia and then we'll discuss about hypermagnesemia. First of all, what is the normal amount of magnesium in the blood? The serum magnesium is very low as compared to other electrolytes. It's 1.3 to 2.1 milliequivalents per liter. Okay. And when we discuss about hypomagnesemia, it means that the serum magnesium levels are very low. First of all, the magnesium is 1% present in the extracellular fluid and 99% present in the intracellular fluid. It means that magnesium is one of those ions that is concentrated more inside the cell as compared to outside the cell. So 99% is present inside the cell and only merely 1% is present outside. It means that if the intracellular depletion of the magnesium occurs, for example, if this amount is depleted, it will not affect the serum magnesium. Okay, the blood values will remain normal because it's a very high amount that is being depleted. It will not affect the extracellular amount. So talking about the etiology of hypomagnesemia, first of all, in etiological part we can say that diarrhea in neonates or in pediatric age group, diarrhea and vomiting plays a special role in the development of hypomagnesemia. We can also mention vomiting. These are the GI causes that relate to the magnesium loss from the body along with the fluid and water. The other is the alcoholics. The person who drinks alcohol has high tendency to develop hypomagnesemia. The third are the drugs. The drugs are not all that we cannot include all the drugs in case of hypomagnesemia. There are specific groups. First of all, it's thiazide. Thiazide is diuretic. Okay, it act on the distal convoluted tubule on the sodium chloride co-transporter. Okay, and the thiazide, what is the function of thiazide is it inhibits the TRPM6 channel in the distal convoluted tubule, and TRPM6 channels is responsible for the reabsorption of magnesium, right? TRPM6 is very specific for magnesium reabsorption, and when the person is on thiazide diuretics, the TRPM6 channel is being inhibited by these diuretics, and consequently the magnesium reabsorption will be disrupted and it result in the magnesium wasting, and that's why the patient can present to you with symptoms of hypomagnesemia. There is magnesium wasting. Okay, thiazide. The second drug we can include is the amphotericin B. Amphotericin B, and amphotericin B is very notorious to cause hypokalemia as well because it causes the potassium shift into the cell as well, and amphotericin B is also notorious to cause the hypomagnesemia. There are no specific explanation how this drug acts, but following the guidelines we can just include it in the drugs variety. Okay, the next drug is aminoglycoside. Aminoglycoside are also very notorious to cause the hypomagnesemia. Okay, aminoglycoside. So we have discussed diarrhea, vomiting. These are GI cause, alcoholics, and the drugs. The last but not the least is the renal wasting syndromes. Renal wasting syndrome means that, for example, Gentleman syndrome. Gentleman syndrome is the syndrome of the distal convoluted tubule. Okay, Gentleman syndrome. And Gentleman syndrome also work exactly the same as the person is on the chronic use of thiazide. Gentleman syndrome. So as in the drug variety we have included thiazide, so that's why we are including in the syndromes Gentleman syndrome, because The Gitelman syndrome explains very well how thiazides work, and it's exactly the mimic the chronic use of thiazides. Okay, it's the dysfunction of the distal convoluted tubule. What is the pathophysiology behind the hypomagnesemia? The pathophysiology, we can write the heading as well. Pathophysiology. It means that how the hypomagnesemia component is occurring in the patient's body. First of all, the magnesium is antagonizing to the calcium. It means that it is antagonist to calcium. Antagonist to calcium. What does it mean? It means that, for example, not for example, but it's indeed calcium causes the constriction and magnesium causes relaxation of the blood vessels. Magnesium is responsible for relaxation, and in the same way, the calcium is responsible for the constriction. It can be constriction of vessels, it can be constriction of smooth muscles. Okay, so the magnesium has antagonizing effect as compared to the calcium. In case of hypomagnesemia, when magnesium levels are low, it means that the vasodilation component is absent and calcium effect is there. Okay, so it result in vasoconstriction. Hypomagnesemia result in vasoconstriction because magnesium effect is inhibited due to hypomagnesemia, but calcium is still there in the blood. So vasoconstriction component will be there. And in the treatment of this condition, we can give magnesium sulfate. We will discuss the treatment a bit later, but magnesium sulfate I can jot down here. Magnesium sulfate, and magnesium sulfate is very important in treatment of eclampsia. Eclampsia is a condition. First of all, let me write eclampsia. Eclampsia is a very life-threatening condition of the pregnant woman because it results in high blood pressure and edema. It affects various organs inside the female body during the gestation period, and it is very life-threatening situation. It develops due to hypomagnesemia. So first of all, we need to treat the hypomagnesemia component by giving magnesium sulfate, right? And this magnesium will certainly cause relaxation of the blood vessels. Okay, so one more thing is very important here, that either if there is hypermagnesemia or is there hypomagnesemia, it does not matter, but there is no specific explanation that hypermagnesemia and hypomagnesemia both inhibit the production of parathyroid hormone. Okay, they both inhibit the release of parathyroid hormone. It means that when parathyroid hormone is not being released, the calcium level inside the body will decrease, because parathyroid hormone is responsible for calcium reabsorption in the intestine. And when parathyroid hormone due to hypomagnesemia is inhibited, in the next step the calcium levels of the blood will start to decrease, and it will cause the manifestations of neuromuscular excitability, so called tetany. Okay, tetany manifestations can also be there in case of hypomagnesemia. Because calcium is low, it will increase the neuromuscular excitability. Neuromuscular excitability will be there, and the patient can have tetany symptoms, excitability. Okay, like flapping tremors and nystagmus, etc. We'll discuss that later. So let's talk about the clinical presentation of the patient suffering from hypomagnesemia. The clinically we can see that the hypomagnesemia has features that are combination of hypokalemia and tetany. As I mentioned, that the drugs amphotericin B not only cause the hypomagnesemia, but it also cause hypokalemia. Okay, the low level of potassium inside the blood, and due to low calcium there will be manifestations of tetany. So hypomagnesemia patients will have the features that are combination of tetany, okay, plus we can write the hypokalemia. These two symptoms we can combine, and then we can get the symptoms of the hypokalemia and hypokalemia. So first of all, combining these two situations, the first thing we can have the muscle. There will be muscle cramps, okay? There will be hypertension. There will be hypertension because magnesium is not there, the calcium is still there. It will cause vasoconstriction, and the blood pressure will start to rise. There will be tachycardia. The tachycardia is well explained due to the fact that vasoconstricted hormone is there in tachycardia. And one of the dangerous ventricular arrhythmias is SARS Torsades D pointus is also very specific to hypomagnesemia as well as it is specific to hypomagnesemia. Torsades D pointus has potential neuromuscular excitability will be there, and as I said, the tetany manifestations will be there. So tetany can include tremors, there will be tremors in the patients, there will be nystagmus. Nystagmus. What is nystagmus? Nystagmus is a jerky movement of the eyes, okay? The eyes will have the jerky movements if there is a nystagmus, and there will be acetosis. Acetosis are the worm-like movements of the fingers of the hand, okay? So these are some clinical features related to hypomagnesemia. Tetany features and hypokalemia features can be combined to put into the hypomagnesemia component. So what is the workup for such patients? What is the investigation that we can put into the trial as we are looking into the hypomagnesemia patient? First of all, virological serum magnesium should be included to check whether the magnesium levels are high or low. So magnesium would be low than 1.3, okay, because the range is from 1.3 to 2.1 milliequivalents per liter. Any value below the 1.3 can be included in the hypomagnesemia. We can check urinary magnesium to conclude that either the losses are due to the urinary cause. Okay, urinary magnesium can be included in the workup for such patients, and ECG. Electrocardiography can also be very useful in determining the hypomagnesemia component. And in case of electrocardiography, we will have prolonged QT interval. It is very pointing towards the hypomagnesemia. It's prolonged QT, and the ventricular arrhythmia that is life-threatening, known as the dorsal okay, and these are some workup for such patients. So let's talk about the treatment that is the most important part of this discussion. As I said that magnesium sulfate can be used. Magnesium sulfate can be used either intramuscular or it can be given IV. So intramuscular or intravenous infusions of magnesium sulfate would be very good for the treatment of hypomagnesemia. These can be the drug of choice. Okay, we can also give parenteral supplementations. Parenteral supplementations, it means that IV supplementations of the magnesium, and we can also give magnesium oxide. Okay, magnesium sulfate, parenteral, magnesium supplements, and magnesium oxide can be given orally as well. So when we are treating the patients with like magnesium sulfate and magnesium oxide, these contain magnesium in a large amount. So while treating the patient of hypomagnesemia, we should watch for reflexes, because if we do not watch for reflexes, if the patient unattended will develop hypermagnesemia during the treatment, the patient will develop areflexia. Okay, there will be development of areflexia. It means that deep tendon reflex would be absent. It will be reduced, or it will be absent, because we are treating the hypomagnesemia patient with magnesium. So if we keep the patient unattended, the magnesium values may rise more than 2.1, it may become 3 or 2.8. Okay, so these conditions are related to hypermagnesemia, and there will be a component of areflexia, and the reflexes are diminished. The deep tendon reflex will be reduced or diminished. So this was for the hypomagnesemia, and in the next lecture we'll discuss about the hypermagnesemia. Till then,